want to just dive down a little bit more on the details of gallium. There was data that suggests that the depth of remission, MRD negativity was important with obinutuzumab regimens versus rituximab regimens, and of course MRD is not really something you can do in follicular lymphoma on a outside of a clinical trial. But does that validate some of the data at all, John?
Well, it's 30 years since I published my first studies on minimal residual disease and follicular lymphoma, I'm embarrassed to say. So clearly for me, this is an important factor, and it's one of the factors that I use to be saying I want to give kind of almost optimal therapy. Driving patients into deep responses as assessed by eradication of minimal residual disease, as an example, is what I'm kind of looking for my patients with indolent lymphomas, where if you're not looking for cure, I'm at least looking to get as deep a response as I can, because to me, that translates into the longest progression-free survival. So I'm personally looking, as I'm assessing clinical trial data, to be saying, where have we got data on MRD? Every single time we've got evidence on MRD, we can see that it matters in that particular trial. That is, the patients, as you might expect, who've got the deepest response have the longest progression-free survival. It's true, it has not translated into routine clinical practice, but it's more and more being adopted, and it's there and it's available in clinical trial data. And I use it to assess how do I think that therapy compares to another in terms of what I can achieve in the patient in front of me.
I really enjoyed reading your papers while I was in high school.
Ouch. I'm amazed you were reading, I was amazed you could read when I was first publishing those studies.
I won't comment on how old I was at that time, or if I was born or not.
So John, this is a very important point. I totally agree with you. The real problem is to apply these kind of evaluation in the real life.
Yeah. Well, that's what I said, Pierluigi. That's why I use what comes out of the clinical trials to help guide me, because you're right, it's very difficult to apply in real life, what tissue you use, how you evaluate it. But you can critically assess what's been done and what's being presented at the meetings. And as you'll see in lots of clinical trials, they've incorporated assessments of minimal residual disease into lots of the treatment approaches to try to get a handle. What it comes down to, of course, is do you then apply it to do these, what we call unplanned subgroup analyses, which I always hate in a study. In other words, here's the group that behaved best, therefore we'll do this. It's the studies often aren't powered to be making those sorts of decisions. But I think you take the whole data together, it's very clear that if you can derive a deep response in a patient, you're going to have that better progression-free survival that our patients are looking for.
Anyway, every time there is a patient, 2 patients, 3 patients with a discordant situation in terms of MRD negativity, but there is a CT scan positivity.
Mm-hmm.
Well, by definition, to me, that's not minimal residual disease.
Yeah.
and too, I think these novel kind of surrogate endpoints are so important in the indolent lymphomas because it takes decades for the data to fully mature. So if you say, MRD correlates repeatedly with survival benefit or whatever we're looking at, that in combination with end of treatment PET, CR rate at 30 months, I think in follicular lymphoma together are emerging as important surrogate endpoints.
So it certainly sounds like this is important to incorporate in clinical trials, but on a day basis, it's hard to do. But let's dial down a little bit on, we touched upon it, but didn't go into depth, the whole issue of maintenance therapy. So Laura, it seems to me like, 10 years ago, almost all my patients received maintenance therapy. And then I was really disappointed by the trials that didn't show they showed difference in progression-free survival, but really no difference in overall survival with giving everyone maintenance therapy. And so there's really been a change in my practice, at least, that it's a minority of patients that get maintenance therapy. But I think there's differences regional. What's your take on this?
So I think compared to some of my colleagues, I'm more of a fan of maintenance. I do offer or discuss maintenance with patients, particularly post the 10-year follow-up of PRIMA. I think that, we were talking before about end of treatment PET scan positive versus negative. It seems like maintenance may neutralize some of that danger of being PET positive end of treatment. And at 10 years post, R-CHOP-like chemotherapy with maintenance, PFS of 51 versus 35 or so percent and maintenance versus observation is something I definitely discuss with my patients. I think I have a very low threshold to stop maintenance if patients are having any side effects, sinusitis, upper respiratory tract infections that could be from symptomatic hypogammaglobulinemia. If it becomes even too inconvenient for a patient, it's not someone I would really push to say, this is going to change your overall course if we continue. But in general, if patients have a deep PR or even a CR, I do discuss rituximab maintenance. I don't use obinutuzumab much in the frontline setting, so I think that's also different. With rituximab, there's not the neutropenia, as infections are typically less, infusion reactions less, so I think it's a generally well-tolerated approach.
John, earlier you mentioned that you wait to make the decision until after you see how the patient does. And so is that they're still PET positive, or what are you referring to when you?
I think it's just, it's funny because, you look at like risk-adapted approaches for Hodgkin's and you think what you're going to do. I kind of just like to see how it plays out. I think that there's some value in getting to know that you get to know the patient over their induction treatment. You get a sense of, are they going to feel better by getting more therapy? Yes, I gauge it a bit on the response as well. But it's, if the patient's having a lot of infections, side effects, is very stressed by their treatment, then, I want to leave them alone at the end of treatment. And I don't always know that at the very beginning because, you don't know how they respond, how they tolerate the treatment, what their preferences are, et cetera. That's it. I think the doctor's influence is huge over what the patient, you can bill it to a patient as if you got to have maintenance or you don't want maintenance. And if you have your biases, I think like most things in medicine, you can influence the patient. I'm not sure that's a good thing. I think ideally we would have a tool to be able to figure out what patients prefer maintenance or where it works for them in their view on the long-term outlook and their quality of life versus others that prefer to be done with you, more or less, at least for several years.
It's interesting, John, so it's just because I would take entirely the opposite approach. That is, that if a patient doesn't tolerate chemotherapy, that's where I would want to give maintenance to prolong the time in which they'd have to face chemotherapy again. Because as Laurie's already said, there's no difference in overall survival, but there's a clear benefit in progression-free survival. So giving a patient a longer period off drug is what I think my patients tell me they want. And if you've not tolerated chemotherapy well the first time, the longer you have until you have to have it again, unless they're very old with comorbidities, the potential they're going to be able to be in a better shape to be able to have it next time.
I guess that BR patient who's in a CR is, when they relapse in 5 years or longer, they're not going to get chemotherapy. They're going to get something else, most likely. So I have a little more optimistic view about the alternatives, for better or worse.
Anyway, so I totally agree with John. So we are using...
Which John?
John's, both of them.
John on my left, UK John. And so because we are using maintenance treatment with rituximab in all our patients who obtain at least a partial response after the chemoimmunotherapy induction. And also, you remember very well 2 years ago at ASH meetings, there was an update by Gilles Sars concerning 10 years, after 10 years of follow-up, the progression-free survival was a statistically significant advantage of maintenance treatment. So no way, the data are really interesting in terms of reduce the risk of relapse for the patient who obtain a CR. And remember that in the preliminary data of the French group, at least 50% of the patients who obtain a PR after the induction can have an increase of the response until CR.
So if you started with one antibody, do you stick with that antibody? I mean,
Yeah.
if you consistently through, is that what everyone's doing?
Yeah, and I think too, as we talk about PFS benefit in this, again, rapidly evolving field, a few years may dramatically, as I agree with both Johns, may dramatically change what you give them in the subsequent line.
Yeah.